Friends, I had a very tough time in managing this cataract. Let us observe the surgery. This is an edited video. First I did the side port and then I did the main incision. The cataract is such that I will not get a very good red glow, so I stain the anterior capsule with trypan blue dye, wash the dye, inject adrenaline. Pupil is moderately dilated. At this time it is more than 5 millimeter. And it's a pretty routine surgery. It appeared like that. The antechamber is filled up with visco, and now I am going to do capsulorhexis. See, there is folds in the anterior capsule. This indicates weak zonule. However, capsulorhexis was easy. It was not tough. And now see what happens. As soon as I do hydrodissection, pupil starts shutting down and the iris starts to prolapse through the main wound. As I inject visco, more prolapse. And the eyeball appears tight. And I be afraid that is there expulsive choroidal hemorrhage starting? I was very much worried at this time. Eyeball is hard. And what to do now, I didn't know. So I closed the main port with a bud, with a Johnson bud, and intermittently pressed on the eyeball. And now I asked for the ball-tipped nucleus manipulator, nucleus sustainer, and I take the iris inside and press the main wound. And a lot of visco comes out. Eyeball becomes soft, and then it appears okay. Intraocular pressure reduces, and I feel relieved that it is not expulsive choroidal hemorrhage. I inject visco, and now I take the B-hex ring, because the B-hex ring will keep the iris, will prevent iris prolapse. The antechamber is shallow, but B-hex is so thin that it can be applied in shallow anterior chamber. I had a very tough time tucking this flange because visibility is poor. There is fluffy cortex. Inject some more visco, and I can see the haptic which is just in front of the main wound. I can see the flange, and I hold the middle tab and try to tuck this flange. But what happens is I hold iris tissue also, and the iris gets pulled, and see what happens. Bleeding starts from the root of the iris. One more problem added, hyphema. I take the Simcoe cannula and aspirate the blood as well as aspirate some superficial cortical lens matter. And I find that the flange which is I have to tuck, whose middle tab is at 7 o'clock, the notch is disengaged. So I go again, hold the middle tab and tuck this flange, and the pupil takes hexagonal shape. Once the pupil takes hexagonal shape, I feel relieved that I will be able to complete the surgery. I remove some cortical lens matter with the help of Simcoe. The bleeding has stopped almost. Some more visco. And now is the time to go into the anterior chamber with the handpiece. It goes bevel down, some superficial cortical lens matter is removed. Then I make the bevel sideways and go into the nuclear mass. The first attempt to chop failed, and now I hold it again, and at this time I could divide the nucleus into two heminuclei. Again I hold on heminucleus, and on easily it could be chopped. And now I take this free nuclear fragment, divide it into two smaller pieces and emulsify. Then I come to the other fragment and emulsify. Ultrasonic energy is set at 65%. Flow rate is 45 ml per minute. Vacuum is 450 millimeter of mercury. This is the last nuclear fragment, and it is taken out. And now the epinuclear shell. We have to be very careful to remove this, because behind this is just the posterior capsule. And as we have seen, this is weak zonule, and we have to take extreme care not to cause any rent in this case. Not only in this case, in every case, we have to prevent posterior capsular rent. And now the remaining cortex is being removed by a Simcoe cannula 23G. Let us think the cause, what could be the probable cause of iris prolapse. I injected visco, and some visco, it was weak zonule, some visco probably went behind the iris, and as I tried to do hydrodissection, the rhexis margin probably got opposed to the iris, and there was some reverse, there was some pupillary block and visco trapped, and that pushed the iris through the main wound. This could be on reason. This is, I'm just guessing. I am not sure. If you have any idea of what could be the cause of iris prolapse in such cases, please share your thoughts. So after cortical cleanup, I fill up the anterior chamber with visco and implant an intraocular lens. This is a hydrophilic acrylic single piece monofocal intraocular lens. The lens tended to tumble. I could prevent that, and now the trailing haptic is placed in the bag. We have to remove the BX ring now. I inject some more visco and then I take the BX forceps, hold on flange, pull centrally and go peripherally, lift up the BX. It comes in the anterior chamber, hold at any place and pull it out. And now I have to clean the visco. First I use 23G Simcoe and remove the visco from the anterior chamber. I am not trying to I go behind the iris and remove some visco. Then I ask for the bimanual irrigation aspiration. I place the irrigating forces over the iris. I am not going to the pupillary area. The flow presses on the iris and it prevents iris prolapse. See, as soon as I go behind the lens, the iris tends to prolapse. Now see what happened. I removed the irrigation first and then the aspiration. Antechamber immediately became shallow and it prevented iris prolapse. Immediately after this, the antechamber was formed through the side port. And now the side port is closed, a final lavage, antechamber is formed and the case is concluded. Thank you very much for your attention. Hope this video will help you in developing your surgical skills. Please share your thoughts. What could be the causes of iris prolapse in this case?